Assalamu alaikum everyone. The next topic of discussion is B12 deficiency, which is also known as cobalamin, vitamin B12. What is the etiology? So one of the etiology is malabsorption. It can be due to decrease intrinsic factor, and the cause of decreased intrinsic factor is atrophic gastritis and gastrectomy. Atrophic gastritis autoimmune is the most common cause, and H. pylori infection. Then we have reduced uptake of intrinsic factor vitamin B complex due to terminal ileum like alcohol, Crohn's disease, celiac disease, pancreatic insufficiency, surgical resection of the ileum, Diphyllobothrium latum, tapeworm infection, bacterial overgrowth, enteritis, and achlorhydria. The second mechanism is malnutrition. So malnutrition, we can have anorexia nervosa and strict vegan diets. Vitamin B12 is found in the meat. Those who are taking strict vegan diets can suffer, but it take only after years. It take years to develop because we have lot of between store for up to 3 to 4 years. Unlike folate, which occur within a few months of insufficient intake, folate deficiency we have folate store for up to 3 to 4 months, while B12 up to 3 to 4 years. So folate deficiency occurs earlier than B12. Other is increased demand like during pregnancy, breastfeeding, fish, tapeworm like Diphyllobothrium latum infection, and leukemia. And we also have drugs like metformin, PPIs, and colchicine. What's the underlying mechanism? Pathophysiology. So, physiologic function of B12. It's a water-soluble cofactor for enzymatic reaction of DNA synthesis via methionine synthesis and arch-chain fatty acid metabolism via methyl-malonyl-CoA mutase. A deficiency of B12 leads to enzyme dysfunction. So we will have dysfunctional methionine synthase, which normally convert homocysteine to methionine, thereby demyelinating in 5-methyl tetrahydrofolate to tetrahydrofolate. So there will be decreased tetrahydrofolate cofactor and purine synthesis, so there will be decreased DNA synthesis. Large nucleated hematopoietic cell megaloblasts will be formed. Megaloblast precursor undergo apoptosis or are phagocyted by macrophages, so there will be pancytopenia including megaloblastic anemia. We will have decreased methionine, so it will lead to neuropathy, and there will be increased homocysteine level, so it will lead to endothelial damage predisposed to cardiovascular disease, can also cause secondary folate deficiency. Another defect, you will have dysfunctional methyl-malonyl-CoA mutase. So methyl-malonyl-CoA cannot be converted to succinyl-CoA. Accumulation of methyl-malonyl-CoA and its precursor propionyl-CoA, as well as their associated arch-chain fatty acids, which cannot be completely metabolized. Propionyl-CoA replaces acetyl-CoA in the neuronal membrane, leading to demyelinations and neurologic manifestation. This demyelination is thought to be due to neurotoxic and myelinolytic factor like TNF-alpha, which are produced due to deficiency of B12, as well as there will be decreased neurotrophic agents due to B12 deficiency. Folate deficiency also leads to low level of tetrahydrofolate, resulting megaloblastic anemia. Then we have most common cause of B12 deficiency is pernicious anemia. It's a type of B12 deficiency caused by autoantibodies against intrinsic factor and or gastric parietal cell, which is known as type 2 hypersensitivity reaction. Anti-parietal cell antibodies target gastric parietal cells and cause decrease in acid production, achlorhydria, and atrophic gastritis. And decrease intrinsic factor production, so decrease B12 absorption in the terminal ileum. Anti-intrinsic factor antibody bind intrinsic factor and block the B12 binding site. It's associated with other autoimmune diseases like hypothyroidism, vitiligo, diabetes mellitus type 1, and it increases the risk of gastric cancer. Now, clinical feature, how the patient will present. So there will be signs of fatigue and pallor, mild icterus and or jaundice due to apoptosis of the megaloblast, and there will be neurologic disturbance which is generally symmetrical. There will be peripheral neuropathy like tingling, numbness, pains, and needle sensation, coldness, especially in the lower extremity, and there will be subacute combined degeneration (SCD) of the spinal cord, which is symmetrical demyelination of the spinal cord tracts that occur in B12 deficiency due to insufficient vitamin B12 dependent fatty acid synthesis and production or maintenance of myelin. It manifests with the following symptoms: paresthesia, impaired proprioception, loss of vibratory sensation, tactile sensation, position discrimination due to demyelination of the dorsal column, spastic paresis due to corticospinal tract, lateral corticospinal tract. So Gait abnormality will be present, and this will result from the damage of spinocerebellar tracts and dorsal column. Long-term deficiency can lead to irreversible neurologic damage, neuropsychiatric diseases, so there will be reversible dementia, depression, paranoia, worsening vision, autonomic dysfunction like impotence and incontinence, and there will be glossitis. We have subacute combined degeneration, so you can remember from S spinocerebellar tract, from C corticospinal tracts, and from the D dorsal column. So these three pathways are affected. Always consider B12 deficiency when evaluating patient with dementia. Now, how will you diagnose the patient with B12 deficiency? Hematologic finding, there will be signs of megaloblastic anemia, decrease HB, increase MCV macrocytic, and increase MCH hyperchromic. There will be hypersegmented neutrophils and decreased retic count. Frequently, thrombocytopenia and leukopenia, possibly pancytopenia, can also occur. If B12 serum level are decreased, determine the underlying cause. Test for autoantibodies, anti-intrinsic factor antibody, anti-parietal cell antibody. If autoantibodies are negative, so perform Schilling test. It's used to determine the cause of B12 deficiency consists of 4 stages that assess impaired B12 uptake. Patient ingests radiolabeled vitamin B12 and then its urinary excretion is measured. Urinary excretion of 8 to 40% within 24 hours is considered normal. No longer routinely used in clinical practice. You can do gastroscopy to look for atrophic gastritis and D-cellulose absorption test to look for any malabsorption. Some points about Schilling test. So in stage 1 we give oral radiolabeled B12 plus IM dose of unlabeled B12, and we measure the B12 level in urine, radiolabeled B12 level. Normal excretion, if we find the excretion is normal, so the cause can be malnutrition or an increased demand is the most likely cause. If there is decreased excretion, so then we go for the stage 2. In stage 2 we give oral labeled B12 plus intrinsic factor, and we measure the excretion, normal excretion, so it confirms that malabsorption is due to lack of intrinsic factor. If there is decreased excretion, so we perform stage 3. In stage 3 we give oral labeled vitamin B12 plus antibiotics. If the excretion is normal, so there may be bacterial overgrowth, and if there is decreased excretion, so we perform stage 4. In stage 4 we give oral labeled vitamin B12 plus pancreatic enzymes. If the excretion is become normal, so there can be a lack of pancreatic enzyme like chronic pancreatitis. If B12 serum level are normal, we measure the homocysteine level. Homocysteine is elevated in both B12 and folate deficiency. We can also measure methyl malonic acid level to rule out folate deficiency, because it's normal in folate deficiency while elevated in B12 deficiency. We have differential diagnosis for B12 deficiency. One is B12, one is B9, which is known as folate deficiency, and we have B1 deficiency, which is vitamin B1, also known as thiamine. So B12 cause subacute combined degeneration and peripheral neuropathy. B9 is folic acid deficiency, while vitamin B1 causes Wernicke's encephalopathy, Korsakoff syndrome, and dry beriberi. What are the causes? So we have discussed B12, which are malnutrition, malabsorption, alcohol, pernicious anemia, and gastric ileal resection. And in folic acid, we have alcohol, drug intake like methotrexate, anti-seizure drugs, and increased demand, for example, pregnancy or lactation. What are the causes for the B1? So alcohol, malabsorption, increased demand in pregnancy, hyperthyroidism, malignancy, increased loss, for example, diarrhea, and hyperemesis, dialysis. Motor signs in B12, we will have spastic paraparesis and lower motor neuron palsy and distal part of the extremities. There are no neurologic symptoms in folic acid deficiency. So remember, this is the difference between B12 and folate, that there are no neurologic symptoms in folic acid deficiency. In dry beriberi, we have lower motor neuron palsy and distal part of the extremities. Sensory signs, so there will be paresthesia, loss of proprioception, vibratory sensation, tactile sensation, in the region supplied by affected segment. And there can be sensory deficits and paresthesia in distal part of the extremity, sucks, and glove distribution. So these are the sensory finding in B12. There are no sensory finding in folate. And in dry beriberi, we have sensory deficit and paresthesia of the distal part of the extremity in a socks and gloves distribution. Other neurologic features, so there will be ataxia and B12. In Wernicke's encephalopathy, we will have ataxia and ophthalmoplegia. Then we have neuropsychiatric signs, so cognitive deficit, depression, paranoia, and B12. There will be confusion, cognitive deficits in Wernicke's encephalopathy, and we also have confusion, cognitive deficit, anterograde and retrograde amnesia, and confabulations in Korsakoff syndrome. So, along with confusion and cognitive deficit in Wernicke's encephalopathy, we have amnesia and confabulations in Korsakoff syndrome. Amnesia can be anterograde and retrograde amnesia. And dry beriberi, we have confusion and disorientation. In diagnostic in between, we have decreased HP increase, MCV increase, and H hypersegmented neutrophil decrease, rate count, possibly pancytopenia, and elevated homocysteine level. These are the same for both B12 and folic acid deficiency. In Wernicke's encephalopathy, we have decreased serum thymine level, so decrease erythrocyte transcatolase activity, increases after thymine pyrophosphate and administration, so increase serum lactate and pyruvate. In B12, we have elevated methylmalonic acid level and there will be decreased B12 level, while in folic acid deficiency, we will have normal methylmalonic acid level and possibly decreased folic acid level. In Wernicke encephalopathy, brain MRI will show hyperintense lesion in any of the following region: mammillary bodies, midbrain, tectal plate, thalamus, cerebellum, brain matter around the third ventricle. In dry beriberi nerve conduction studies, signs of axonal sensory-motor polyneuropathy will be there. Management of B12, so IM administration of B12, folic acid, oral folate supplementation. In Wernicke encephalopathy, we give parenteral thymine administration followed by oral thymine. Prognosis is potentially reversible. Folic acid is also reversible. Dry beriberi is mostly reversible. Starting folate treatment before excluding B12 deficiency may correct anemia, but it may worsen the neurology. In contrast to B12, folic acid is not associated with neurologic symptoms. These are other causes of macrocytic anemia, and these are the causes of neuropathy. Then we have treatment. So we have IM supplementation of vitamin B12, cyanocobalamin, hydroxycobalamin. Prevent future B12 deficiency by treating the underlying disease. And if causative therapy is not possible, lifelong IM supplementation may be necessary. Secondary folate deficiency. Folate supplementation can improve and mask hematologic symptom but has no influence on the neurologic symptom of B12 deficiency. So that's all about